Today, I have the honor and privilege of speaking with Dr. Susan Ott. Dr. Ott is going to cover the long-term effects of osteoporosis medications. In the late 1970s, Dr. Ott completed a residency in family practice, and the following year, a residency in internal medicine. A few years later, she completed her training to become a nephrologist, a kidney specialist. Over the years, Dr. Susan Ott would go on to do studies on the effects of different medications on bone. Taking small samples of bone from live individuals, known as bone biopsies. When they do bone biopsy, they take a small amount of bone, typically taken from the iliac crest of the pelvic bone. She would take those little bits of bone and spend thousands of hours counting the different bone cells and measuring what effect the drugs had on those bone cells. The drugs she studied included bisphosphonates, Alendronate in its early development, and Estrogen. By 2001, she wrote one of the earliest letters questioning the long-term safety of bisphosphonates and eventually published a major study on the incidence of atypical fractures with long-term usage. Beyond the bisphosphonates, she's looked at the impact of calcitriol, raloxifene, as well as injectable and oral birth control medications. Aside from seeing patients in the orthopedic clinic, Dr. Ott is also a professor in the Department of Medicine in the Division of Metabolism, Endocrinology, and Nutrition. She is adjunct professor in orthopedics and sports medicine, as well as radiology at the University of Washington in Seattle. 20 years ago, through her educational website that she started in 1998, unbeknownst to her, Dr. Ott was instrumental in helping me understand bone, and I look forward to learning more from her today. And so, Dr. Ott, I'm going to pass this on to you.
Okay, well, thanks a lot for your introduction. And I'm going to start off with this little talk about osteoporosis treatments. And I don't have any conflicts of interest. And the first series of slides is actually going to be some animations of what we think happens to the bone cells based on looking at the bone under the microscope. And BMU means one basic metabolic unit. So this would be a tiny little piece of bone way down inside the middle of your bone. And we color it green. Now your bone is actually white, but when we look at it, we have to put some stains on it so we can see it. And so when you see anything green, that means it's bone. And when you see things that are red, that's just the cartilage that's forming into bone. Now, what happens in this movie is pretty quick. First, you see a little crack, because that happens all the time when we step funny or fall over. And the bone's going to dissolve the crack away with the kind of cells that dissolve your bone. Those are called osteoclasts. And then it fills it back in again with the bones that make new bone called osteoblasts. So let's just watch it. There's the crack. Here come the cells, big cells that dissolve it, and then they're followed by the cells that make it, and the new bone is red, and then the green means it's mineralizing. Fill it back up again. Now we've repaired the bone. And if you'll notice, the color is getting a little darker. And what that represents is now calcium is coming into that brand new bone to make it hard. All right. So that's what happens in one tiny area of your bone. But in our body, we have millions of areas like this. And so we're going to do the next picture. We're stepping back a little bit. Now, this would be about as much as a millimeter, which is very tiny. And we're seeing now about 7 places where your bone is in the process of dissolving and filling up again. And I'm going to speed up everything so that in a few seconds, we're going to watch 3 years of what happens to your bone. The idea is that the bone is alive. So it's just always refreshing itself. don't think of our bones as moving or being alive. But I want a different view. I want you to think that the bones are always repairing. And imagine now, if our bones didn't repair, it would be like a pillar on a freeway. And you've seen reports every once in a while how a bridge collapses because the pillars get a lot of little damage and they don't get repaired. Our bones get little damage too. And what makes them alive is that we repair them. So things can go awry, however. And the next one shows what happens to this process during menopause. And what's happening is you're unfortunately, when you are dissolving the bone away, you dissolve more than you need to. And so you're going to make little holes in your bone. So let's just watch that. So this is just a few years after menopause, and I'm going to show it twice so you can watch it again. But pay attention. See right here, we've made a hole. Here, there's another one because you're dissolving on both sides and you break it. These are literally little holes in your bone, and they weaken your bone. And that's the main reason that women get osteoporosis. So I can do this over again, I think. Here we go. Let's just watch it one more time to get a sense of what's going on. Okay, so now what we're going to do is show you what would happen with the various different medicines that we use. And the first one is estrogen.
Dr. Ott,
Yeah.
Before you, may I ask a question?
Yeah.
So when we were watching that, that is a totally healthy individual going into menopause, and just the fact that they have less estrogen in their body, the bone cleaning, the osteoclasts now have a little more free range, are more active, and that's what happens.
Yeah, when you lose estrogen, it's inevitable. You're going to make holes in your bone. And not only have we shown that in the studies looking under the microscope, but there are some high resolution imaging studies you can do in normal women. And after 2 years after their last period, you can actually see the little holes just the way we predicted. Okay. So now what we're going to do is show what happens if you give back estrogen. So this looks a little bit different because I've made it so you maybe have developed a little bit of osteoporosis. But for the first 6 months, the bone is just, doing the constant, we call it remodeling. And then when the medicine starts, it slows it down. And it's actually pretty subtle. But that's because these are all drawn to scale. All right, so now the medicines start right now. And we're just not dissolving and forming it quite so fast anymore. So it's going back to the normal rate. But there's something important. There's something that you don't see. And that is you're not seeing the formation of these holes or perforations. And because of that, this treatment will keep your bone stronger than if we just let the process of bone turnover keep on going.
And on that slide, you had, beside estrogen, you had SERM.
Oh, yeah. So that stands for selective estrogen receptor modulator, which is a real mouthful. And there's actually only 2 medicines in that class. Only one do we use for osteoporosis, and that's called raloxifene. And I do always use the real words, the generic words. I'm just too academic, I guess, but I don't like to use brand names. So we're going to show the next one is a treatment with bisphosphonates. And there's a whole category of them. They all work the same way. In this one, you're going to see 6 months where we're not giving anything. And then you see little diamonds come in. And the diamonds attach to the bone and they prevent you from dissolving your bone. So we're going to watch this one once all the way through and then once again after I talk about it. Here we go. Now, here come the little blue dots. And all of a sudden, things stop being so active. There's maybe only a couple of places where anything's happening and all the rest of the bone is just sitting there. And you might notice that it's getting darker. And what that represents is that more mineral is getting in now because you're not remodeling your bone. The calcium can come into the bone and make it denser. You might also notice that I put a few little cracks in there. And we can see those under the microscope in people taking these drugs, that you get little tiny microscopic cracks in your bone. So let's just watch that one more time. So you start doing the turning over. Very few places left. And so you don't have, your osteoclasts don't work. And so you can't dissolve away these cracks. And that's important in the long run. But on the other hand, you're also not, again, you're not getting any perforations. So you're preserving the structure of your bone. And that is a good thing. And it's especially a good thing in the beginning. So now the next one is Denosumab. That's a newer drug. And this is the one given as a shot. So we're going to go along for 6 months and then you get a shot. And then you do it every 6 months. We're going to give a shot. And then at 12 months, at 18 months, we're going to say, oh, let's stop. And then you'll get to see both what happens when you're on it and when you're off it. Okay, here we go. Here comes the first shot. It just really freezes things. Second shot, third shot. Okay, now it's wearing off. And almost immediately after it wears off, you get this sudden surge of dissolving the bone. Okay, so that goes pretty fast. And I'm saying I'm doing this according in scale, so that's why it goes fast. So let's just watch it once more.
The little forks, sorry, but the little forks what are these little forks or
That's the Denosumab.
Oh, so it's just floating around. That's
what they look like. They're immunoglobulins.
Oh.
Okay, so immunoglobulins are Y-shaped.
Oh, okay, thank you.
Okay, that's okay. There we go. And it's just showing that they're there.
Okay.
There, now they dissolve and away you go. And actually, the bisphosphonates were represented by, those do go and stick inside your bone. But the Denosumab is in the marrow spaces. Okay, it's not sticking to your bone. It's in the marrow and it's preventing you from forming the cells that dissolve your bone. Okay.
So can I ask you a question at this point?
Yeah.
So I noticed with the bisphosphonates, the bone got very dark and
right.
there was little cracks. Now with the Denosumab, it stayed a healthy color.
Well, it's getting darker, but I didn't keep it going very long.
Oh, that's right. Okay.
Okay. Yeah. And it eventually is going to also get darker, just like with the bisphosphonates.
And would it also then get little cracks?
We think so.
So we only know. Okay.
I have not yet seen anybody look after 5 or 10 years with Denosumab.
Okay.
Okay.
Thank you.
Now we're going to look at another one, which is called Teraparatide. And this one also, you're going to see that the Teraparatide looks like a little ball. It also just goes into the marrow space and will stimulate the cells that both form and dissolve your bone. And we're really going to have to watch this twice because a lot of things happen all at once. You form a lot of bone and you dissolve a lot of bone and you make little tunnels in it. So let's just watch all the action. Here we are, nothing. Here we go. And now it stops because when they did the studies, they stopped the medicine on average of 1.5 years when they did the study. And so we don't keep going with it. And typically we'll use this drug for 1 or 2 years and then it just doesn't work anymore. So we have to switch to something else. And you might notice that it's a lighter color and it's just the opposite. We're making all this brand new bone that hasn't had any time to even accumulate very much of the mineral yet. And you might notice that we formed a new tunnel here. We formed a new little piece of bone here. It's actually more complex than it was, and that makes it a little stronger. And we overall have more bone. We've dissolved some, but we've formed even more than we dissolved. So just one more time, watch that go. Okay, now we start giving the drug. Of red is the cells that are forming new bone. So that's teriparatide. And there's another one that's very, very closely related called abaloparatide. And they both work really the same way. So it would be the same movie.
Can I ask you, you
Sure.
mentioned with the teriparatide that it's all the bright green bone because it's quite new. Mm-hmm. And so therefore, how long is it? Because in my eyes, then that's a little bit more fragile if I was prescribing an exercise. How long is it a little bit more fragile for before that new bone starts to?
So the new bone is it's a little bit softer, not fragile as much as breaking. I think of fragile like glass where it's brittle and breaks easy. This is more like silly putty that is a little softer but doesn't break. And it takes about 3 years to get to fully mineralize it. And it may be even in some places up to 5 years where you're still putting mineral into the bone. So it's a pretty slow process. It doesn't go evenly. You do it faster at first and then slower and slower. But even after 3 years, you're putting a little bit more in.
Thank you.
If you overdo it, actually, then your bone gets brittle. Okay, so now you have bone that is getting more like glass. Harder, but easier to break. And when you break, it shatters.
And that's if you overdo the last one we just talked about, the teriparatide?
Or actually, if you overdo mineralization, and that won't happen while you're giving the teriparatide because you only give it for 2 years. But that can happen if you can give something where you keep mineralizing it for 5 or 10 years, like the bisphosphonates, or continuing the Denosumamb.
Okay.
Okay.
Thank you.
And it's the newest one. And the Romosozumab does both things. It stops you from dissolving your bone and it increases the formation of new bone. So when we give it, almost immediately you start forming a lot of bone and you're not dissolving very much. But then with time, the part where you're where you're forming your bone, you just slow down again. So it's actually pretty complicated, and we'll just watch how this goes. So this is baseline. Now we give it, and it goes really fast. You make a lot of new bone, but then you start to dissolve some of it away again a little bit. And again, we only use this one for a brief time. And again, it looks like a little Y because it's another antibody. Okay. And we actually got a lot of bone. So you can see it's really thicker here. It's thicker all over the place. And it's lighter because it's new bone. Okay. And you're doing a little bit of dissolving, but not as much as you were in the beginning, just a little bit.
May I ask another question on that one?
Yeah.
This is one of the conferences I attended. They were saying about that drug that most of the bone building happens in the first 6 months, but
Right.
It looks like this continuing on for 12 and 18 months. But I believe the time period that it's supposed to be given is a year. Is that correct?
Yeah, and we gave it as 6 months, and the really fast bone formation was going on for that first 6 months. So that was going from 6 to 12 and a little bit more, and then it's slowed down.
Oh, okay.
Okay.
Thank you.
Okay, so at this point, I was going to talk a little bit about the effects of the different drugs on what they do in people. And I know that you asked to say something about estrogen particularly. And one of the things I wanted to say about estrogen is when you compare it directly to alendronate in women who are right around the age of menopause. In this study, they were 40 to 60 years old. The estrogen improved the bone density greater than the alendronate did. And both of them were better than placebo. So this shows how this is the spine bone density after 4 years. Women who got randomly put into one of three groups, and the ones who were given the placebo did what we always see, they lost bone. The ones who were given the alendronate gained bone. That's the blue line. The ones who were given estrogen gained even more. Now they gave two different kinds of progesterone along with the estrogen. And this pink line, actually, we don't use anymore. But the red line is estrogen with a progestin. And this was significantly better than alendronate. And hardly anybody knows that. They all think that alendronate is better than estrogen because of the advertising and not because of the data.
And alendronate, just to remind people, is a bisphosphonate.
Right. It's the major one that's used most of the time, the oral one.
Thank you.
So then we get to the actual title, which is the long-term effects. And we'll start off with estrogen. So long-term, this is a study that was done actually in 2002. So it was 20 years ago, back when women were using estrogen more than they are today. And it was a large federally funded study that has given us most of the information we have about the epidemiology of osteoporosis. And it was called the Study of Osteoporotic Fractures. So this study enrolled almost 10,000 women in 4 different cities throughout the United States. And they all had to be older than 65. They did a lot of publicity, invited anybody who would come and agreed to participate. And so they had a lot of women, and they tried to measure just about everything they could. They asked long questionnaires. They measured bone density. They measured grip strength, dietary things, medical things, everything. And then they followed them. They just observed what happened to them for the next 11 years. And this is the results of what happened to the women who took estrogen compared to the ones who did not take estrogen. on the rate of how many fractures they had. So these were, they call them non-vertebral fractures, because the vertebral fractures can only be counted by taking x-rays and not by a questionnaire. So at the beginning of the study, since they were all older than 65, the average woman had been taking estrogen for 24 years. And then by the time that it ended, the women on average had been taking the estrogen for 35 years. And you can see that during this entire time of the study, the ones who used estrogen had a lower fracture rate than the ones who did not use it. So 35 years of estrogen group, and by now, these women are all older than 75. So they're 75 to up to 90. They're actually having fractures that are less than half as many fractures as the women who did not choose to use estrogen. And this kind of data is not available for anything else. None of the other drugs are long enough that anybody's taken them for close to 20 years. Now, the bisphosphonates are just starting to get to 20 years, but there's not very many women who started right around when they first came out in 1996. There's very few women who are still taking them. What happens if you stop? So this, now we're looking at a more recent study that was published a few years ago in the Women's Health Initiative, which compared estrogen to a placebo pill. And the study lasted about 7 years. And then they followed up what happened to them after they stopped. And there were two groups. One group also got a Provera, which is a kind of progesterone. And so in this group, the estrogen plus Provera group was a little bit lower fracture rate for the first 3 or 4 years. And then the fracture rate was the same as the women who were not on estrogen. But it's not higher. It just, it's the same fracture rate as if they hadn't taken it. And this group of women only took estrogen. And so the women who only took estrogen are in the dotted line, and the ones who took a placebo were in the solid line. And then they stopped. And after they stopped, the ones who had been on the estrogen actually had a lower fracture rate all the way up for 5 years. Now, eventually, it would also catch up. So if you stop taking estrogen, eventually you stop getting the fracture prevention, but you don't get any rebound. It doesn't make you any worse off than you would have been. And you maybe have 5 or 6 years of lower fracture rate. Okay. Now, the story is not the same if we look at the bisphosphonates. And we talk a lot about atypical fractures. So I'm showing you the difference between a typical fracture and an atypical fracture. And I'm comparing it to a log. So this is your femur. The hip is on this end. And this is the kind of fracture we see in women who have probably pretty serious osteoporosis. And the bone here is looking thin. You can see it broke in several pieces and splintered. And that kind of looks like what happens when a tree breaks while it was living in the forest. It got blown over by a hurricane or something. The live wood splinters when it breaks. Now, this tree was actually petrified. So this is from the National Park, Petrified Forest National Park. And this is a very heavily mineralized tree. Remember when we talked about mineral going in? Well, the same thing happens to a tree when it becomes a fossil. The mineral seeps in to the tree. That tree is not any bigger than it was however many million years ago. It's the same size, but it certainly is denser. And if I measured it, this would be very dense. But look how it breaks. Mineralized mineralized wood breaks in this sharp sharp line, kind of like a crystal. And that same sharp line, can you see right there? And right there? That's what we call an atypical fracture. It looks like instead of just splintering, It's breaking like you're cleaving a crystal. And that's a very unusual appearance. And we call them atypical because we really don't see them very often. But they are a sign of long-term use of bisphosphonates.
May I ask a question about those photos? Because, if I was a surgeon, I'd go, oh, well, it would be able to put the atypical side ends back together a lot easier than the typical ends. But I believe, and maybe you can clarify this, is the amount of force or what type of, bones do you see this because someone's been on a particular medication? And then what is the healing like between a typical and an atypical fracture, or the results that?
Well, there's always individual differences, but in general, the typical ones heal better. And the atypical ones, they may look like it's easy to put it back together again, but the bone's more brittle. And so it'll break on you. Whereas this bone is softer. And so it's easier to manipulate it around.
Oh, interesting.
And in both of them, you're going to try to thread a metal rod through this. Now this one would be challenging to the surgeon, but so is this one actually. And the need for second surgeries is greater in the atypical ones. Okay. And the incidence of these goes up with duration, but it takes a while. So this is looking at a large number of people from Southern California. And we looked at all of the people who had a fracture in their femur, at the ones who had an atypical fracture, according to how long they'd been taking bisphosphonates. Most of them were on alendronate. So it was very rare. There were only, I think, 13 people out of about 1 million who had that kind of fracture if they were not taking the bisphosphonate. Then if they took it for 0 to 2 years, you saw a little bit more. And the reason there's 2 bars, one is just the rate as it came in, and the gray one is the rate when we adjusted for how old they were. Okay. So as you take it for a longer time, you can see that we're seeing more and more, and it especially starts to go up after 8 years. It's really big jump. So by now, in the ones who are taking it for 8 to 10 years, we're seeing 1 in 1,000 women who are getting these unusual fractures.
And can you remind me, you said in the normal population, it's 1 in?
Well, in the normal population, it's about 1 in, well, we saw 13 in about 1 million.
Wow, so that's like a huge increase.
Yeah, it's very rare. And it's actually, and I want to point out, it's actually in these first 4 years, it's really very unusual. Okay, although it's starting to go up, it's still, this is, if you look here, 20 per 100,000. Okay. But by the time you've been taking it for a long time, 1 in 1,000 is not all that, it's not all that rare, and you're going to see it. You only need to see 1,000 people, and you've got a chance of seeing one. Okay, so that's what we're worried about if you take it, the alendronate, for a long time. And what we're still uncertain about is, what about ordinary hip fractures, or the typical fractures? We know for sure that during the first 5 years, the typical fractures are reduced. And so it really does work. You can look at study after study. If you add them all up, I added up, there were 35,000 people enrolled in these studies, and they had fewer fractures. So that's very clear. But the question is, what about after that? The studies all seem to kind of end. And with long-term risk, it looks like maybe it isn't working as well. And so you might start to see more even ordinary hip fractures with the bisphosphonates, but we don't really know yet. And actually, I can say that there is a group of us right now, as we speak, that are putting together a really large study to look at that question. Okay, but we won't know the answer for a few years. I'm going to now say what happens when you stop.
Yeah.
What happens when we know if you stay on the drug for 10 years, you get more atypical fractures. Well, what happens if you stop? And that's a really important question that has some controversy around it, but there was a good study where they randomized women who had been on alendronate for 5 years. And during that 5 years, they had all taken alendronate. And then they randomized them into 3 groups. One group got a placebo, and that's colored green. One group got, 2 groups got alendronate, and they were different doses of alendronate. And so then they followed these women for the next 5 years. So you remember that everybody at this time point, everybody has been on it for 5 years. So by this time point, the ones that are in the green line were on it 5 years and off at 5 years. The ones in the black and red line have been on it for 10 years altogether. And the fracture rate's the same. So it doesn't matter if you quit, and the reason
after 5.
Huh?
It doesn't matter if you quit after you've been on it for 5 years.
5 years, yeah.
Okay.
And the reason that it keeps I have to add that this fracture rate is considered a low rate. If we just looked at women who had osteoporosis and hadn't been treated with anything, we would see a fracture rate about twice that fast, okay? So what's happening is the medicine is still stuck in the bone, and so it's still having a lingering effect, and you can just go ahead and stop it. And the good thing is that you avoid those atypical fractures. So this is the case, literally, you can have your cake and eat it too. You can take the alendronate for 5 years, and then you can stop it. You'll get 5 more years of protection, and you won't be getting those atypical fractures. So you can't ever be absolute in medicine. So there's always going to be somebody who gets an atypical one, or somebody who, but in general, you can safely stop this drug after you've taken it for 5 years. And I actually think that's what you ought to do. But it's still a very controversial point. Now, one of the controversies is that some people said, well, yeah, but maybe the ones who were really at the high risk, who had the lowest bone density, maybe in those people, you need to stay on it the whole time, and you shouldn't stop it. But they actually looked at that. And before I go on, I want to report one little detail. The data that I'm showing you here was in the FDA report, and the FDA is not biased. So it's one of the few reports you're going to see where nobody's getting paid for saying one thing or the other. And that, unfortunately, is important. This is the same thing I showed you before, except we're only looking at the ones who had bad osteoporosis. The bone density here was -2.5. And it still didn't matter. The ones who were on the placebo still had the same number of fractures as the ones who were on the alendronate. So even in the people who have osteoporosis, it's fine. You can just stop it. Yeah, so we also, I had one about how we stopped estrogen, but this is how we stop, what happens when we stop denosumab. So denosumab, there aren't any studies about really long-term use. There's only one small follow-up. There were about 1,000 people that had taken it for 10 years. And they did have, a couple of them got the atypical fractures, okay? So for all we know, the rates could end up being about the same as long-term bisphosphonates, but there's not enough people who've been on it for more than 8 years to be able to give you that information yet. After you skip a dose of denosumab, you get a series of fractures. You can get a series of fractures in your spine. And if we look at this X-ray, you can see that this patient was on denosumab, did not have any fractures. They're all looking like little boxes. And after skipping one dose, and this would be maybe 3 or 4 months after you were due for the next dose, we can count them: 1, 2, 3, 4, 5, 6 fractures in the spine. And I just have another example of that right here. Here's one that was published, another one that had been taking the medicine for 4 years and then stopped it. And before she stopped, it looked like this. And afterwards, we can again look at their squish. There's 1, 2, 3, 4, 5 fractures. This one is the only one, and this one. Those are the only ones left that look normal. Okay, so what's the risk of getting this? Well, it's actually really pretty high. And this is recent study. They went back and looked at the first large study of denosumab, and they called that the Freedom Trial. And in that study, the women were assigned, again, they were randomly assigned to either get a placebo or to get the denosumab. And that trial actually ended up going on for 10 years, 3 years when they were all randomized. And then they had a follow-up period. And so what they did is looked at the ones who discontinued the medication to see how many fractures they had in their spine. And the first graph is the ones who had been on placebo, and they discontinued it. So there were 327 of them. And if you were on, so you were never on any treatment and you just got tired of being on the study and you discontinued, but they still followed you. You just didn't take a drug. You saw a rate of about 3.5% of these women had multiple, that means more than 2 vertebral fractures, well, 2 or more. Now, this group was the group that was on denosumab, but they quit the study early. So they'd only been on it for less than 3 years. And so they weren't all that different than the ones who were on placebo. And this is the group that had been on the denosumab for greater than 3 years, and then they stopped. And we have 200 women in that group. And about 7.5% had multiple vertebral fractures. And I colored in red the ones who had more than 4. So almost half of these people, they stopped it, they had more than 4 fractures. So that means out of every 100 women who stopped denosumab, about 7.5 are going to have 2 or more fractures in their spine. That's a higher rate than we generally see with ordinary osteoporosis. And it's really kind of a scary thing to think. So what are we going to do? Are we going to stay on it forever? When we don't even know what happens after a long time, because nobody's been on it that long? Or do we stop it, but then you might get these fractures in your spine? So some people have thought, well, maybe instead of stopping it, we could switch over to a bisphosphonate. And so Alendronate's the most powerful one we have. That's the one that you give as an intravenous injection. And even when you give Alendronate in these people, they are going to lose bone. And we don't know yet if it's going to help to stop these multiple fractures. It probably will help a little bit, but they still lose a lot of bone. So here you're on the denosumab in this group 7 years, And then you give Alendronate and you still go down to lower than you started from. And a lot of people say they don't want to take a bisphosphonate, so they're going to take Denosumamb instead. And then they take it a while and they discover that if they stop, they're going to end up back with a bisphosphonate. I actually think that if you're bad enough to need a medicine, you might as well start out with the bisphosphonate and not go through the risk of having this. But these things are still really pretty controversial, and the medicine is still being used a lot, but there's a lot of ignorance. And I know a lot of doctors don't actually still know how high this risk is. 7% is high, but their attitude seems to think it's like 1 in a million or something. And it's just going to take a little bit of time before we see more and more of these.
May I ask on that last study?
Oh, sure.
No.
Where to go? This one?
Yeah. Do you happen to know when the Alendronate was given?
Yeah, it was given at the time of, it was given right when they were due for their next shot of the Denosumamb.
So at the 6-month mark after stopping.
And there's various different studies that are getting done right now to see if it matters when you give it. So far, it hasn't been very encouraging. They're seeing the bone loss, at least they're seeing that with when you give it right away, or when you wait a few months, or when you wait until some blood tests come back. They keep losing no matter what you do.
Okay.
Okay.
Dr. Would you mind just giving some advice to individuals that are currently on Prolia in regards to how if they're 60, 70, 80, and what they should be considering?
No, this is a really important question. And so Prolia is the same thing as Denosumab. The question is not got a really good answer yet. I just recently been at a meeting of all the people who were interested in bone research, where there was a long session about it, what to do. I can tell you where we are now, but it's not quite satisfactory, and I think it's going to change when we learn more. There's one group of people who say, well, just keep taking it. But they're saying that without any confidence of how safe it is. And with the real possibility that if you keep taking it for longer than 7 or 8 years, you'll see the same kind of problems that you see when you just keep taking bisphosphonates, and it will make your bone brittle. So it's a little unnerving to be told you have to take it every 6 months for 40 years if you're only 60. But you can't stop because of the risk of these fractures. So the current thing is, well, you seem to be able to avoid most of the risk of the fractures if you will switch to getting an intravenous form of bisphosphonate, which is called Alendronate. And a lot of people didn't want to use the bisphosphonates in the first place, and they got put on Denosumab, and now they're finding, kind of to their dismay, that the only way they can stop is to get the bisphosphonate. So that's currently what we've been doing. The risk, it looks like the risk of these fractures goes up the longer you're on it. So if you're going to come off, you ought to come off soon. And then if you've only been on it, all the people who've only been on it 1 or 2 years, it's kind of easy. They're not going to run into too much trouble, and they can pretty much be treated with 1 dose of the Alendronate, and that's that. But once you've been on it for 5 years or more, you might need 2 or 3 times. Unfortunately, there's a lot of people like that right now. And I will say, to be maybe a little reassuring, that the Alendronate's actually pretty safe. And there's not very many people who can't take it. There's a lot of people who don't want to take it, or they they didn't like the fact that they had a fever afterwards, but that's a transient thing and doesn't cause any permanent damage or anything. So it's generally a very safe medicine. It's and it'll definitely be better for you than just stopping it. With time, we might find some other solutions. I'm not sure. I'm running into some really difficult people who have this trouble with the jaw that we're worried about. We know that can happen with the Prolia. But it also happens with this Alendronate. So that would make your jaw even worse. And in that case, there is this brand new drug and people are looking at it and there really is no really good answer yet. So it's one of the things I'm definitely looking at. Question I asked at the meeting, I said, hey, I read everything I could. We have what we call PubMed. I've searched all the things that have been written in the medical journals for what do you do to get off of Denosumab. And they all say, well, you can have problems with atypical fractures, but jaw osteonecrosis, but they're rare, period. I have not found any solution, any answer, anybody saying anything except they're rare. And I say, well, that's all that good, but if they're rare, how come I have 4 of them? You know, so we don't know, and we're trying some of the new drugs. We cannot possibly be at the point where we say we recommend them or anything because we really just don't know.
Okay.
And if you're not taking it yet, this might be a reason not to start.
Until they know how to take people off it.
To know what to do, how to get off of it.
Yeah.
Yeah.
Okay. Well,
okay. Kind of a little scary when you think about how many people are still using it and recommending it.
Yes, and although they'll say, make sure, either before a bisphosphonate, the infusion, or Prolia, have a good dental examination, but our teeth change. And I have clients that are wanting to have implants, and the dentists are telling them to come off with the medication, and then where do they go? But they can't have an infusion because the zoledronic acid is just as hard, to help the healing. So then they're stuck between, getting implants or not getting implants. And
it's really a problem that we're having right now. So.
Okay, well, really want to thank you for sharing your wisdom, knowledge, and your inquisitiveness on, always asking and you could tell that, you're looking out for your patients, which is really lovely. And I know people feel that, and I know you're going to be inundated. So I should ask you, are you taking any new patients? And do they have to be in the state of Washington?
They do have to be in the state of Washington. And that's a university policy. I think it's even a Washington state. It's called practicing out without a license if you practice anywhere else. And I am cutting back a little bit. And so I've said no new patients. And then I said, well, if you and generally if the patient's physician is just lost and asks me to help, I have a really hard time saying no. So I'm still seeing a few, and my goal is to try to find a couple of other younger people that will also take over, and then we'll see if we can do that. There's not enough young people who are interested in bones. It's too bad because they're fascinating. Yeah. Okay.
Thank you so very much.
All right. You're welcome.
For more interviews on pharmaceutical and bone health, check out this playlist I created just for you.